This video will explain how nurses and other healthcare professionals can use the Beers criteria and other guidelines to work with the interdisciplinary team to review and monitor medications for older adult patients and reduce the likelihood of medication-related adverse outcomes.
Mrs. Lyons is a 73-year-old female who was admitted to 3 West after falling at home. She was recently started on amitriptyline 50 milligrams, so this might be related to her fall. We did do a fall and syncope workup. She was on telemetry for 24 hours, which I think was didn't show anything, and she's also on fall risk precautions. Her other medical history includes type 2 diabetes, hypertension, coronary artery disease, osteoarthritis, and mild incontinence.
We feel that your medications may resulted in you to fall, the reason why you're here. So we're going to just review them. This is Donna Fick.
Hi, Evelyn. My name is Donna Fick, and I'm a geriatric nurse specialist here at the hospital.
And because she fell, Evelyn, you're wearing a pink bracelet, and that means that you're not allowed out of bed by yourself because you do have a history of falling, and we don't want you to fall here. We want you to be safe, and if you need to get out of bed, there's a call bell on your bed. We want you to ring for that and wait for our nursing staff to come and help you, if you need to go to the restroom or whatever have you, okay?
Okay.
Did you bring a list of meds or the medications with you?
Well, actually, I brought them, but I realized that I forgot some, so
Okay.
I have some of them.
That's okay, as long as you're pretty knowledgeable of what medication she's taking.
Yep.
Good.
Okay.
The new medication that you started 3 days ago is the amitriptyline. We have written here that you started that 3 days ago for neuropathy, and it's a dose of 50 milligrams daily.
Correct.
Good. Okay. And then your other medicines that you're on is oxybutynin 5 milligrams twice a day. Do you know what you take that for? Do you know? We use it for incontinence.
Oh, okay. Your bladder.
Yeah, your bladder pill, you might know it as.
Okay.
And then the Lipitor 40 milligrams daily.
Oh, I forgot that.
Okay.
That's in your
all right.
bedroom, isn't it?
I think so.
Okay.
Yeah.
I didn't bring your bedroom.
That's
then.
okay.
Yeah.
All right, so you take that every day, the
Yes.
Lipitor. Okay. All right, and lisinopril 20 milligrams daily for your blood pressure, I assume.
Yes.
Yes? Okay. And
I
last?
don't have that.
That's okay. And then we have digoxin 0.25 milligrams. You take that
Right.
once a day?
Yes, ma'am.
Yes.
Good. Okay. Diazepam 10 milligrams, and that's as needed. So you take that. How often do you take it? Do you think like twice a week if you need it?
Maybe once.
Okay. We also have listed here Darvocet and Tylenol as needed. Do you know what you take those for?
Yes, ma'am. They're for pains in my knees.
Okay.
Can you tell us more about the pain, like where you have the pain, what kind of pain it is, and how often you take the medicines?
Well, just once in a while when I'm walking, it'll hit me, and sometimes I just about go down to my one knee. It'll just like somebody goes up behind you and puts their knee behind yours,
So it's a sharp grabbing pain.
Yeah, and I about go down with it sometimes.
And how often do you take the Darvocet when you have that kind of knee pain?
Oh, probably once or twice.
And what about the Tylenol? Is that just as needed, or do you take it
As
regularly?
needed.
So
As
it's
needed.
Okay. And then how often do you take the Tylenol? How many times?
Maybe twice a week.
Okay.
Do you take anything for sleep?
Sometimes you take that Tylenol PM.
Yes, I do.
Tylenol PM?
Yes.
Okay.
Do you take that every night to help you sleep,
No.
or how often?
Maybe twice a week at the most.
Do you do anything else to help your sleep?
Well, usually Saturday nights I'll take the 2 nerve pills because it puts me to sleep quicker, and because I have to get up and go to church in the morning,
Okay.
Sunday morning.
Okay, but you don't. So you take the nerve pills, but do you do anything else to help you sleep besides medicine?
No.
Okay.
Anything for diarrhea or constipation?
Yes, but I
Okay.
can't remember the name of it
Okay.
right at the moment.
All right. Maybe when your daughter goes home, she can bring that container in.
It's Colace.
Colace.
She takes
Okay.
Colace sometimes.
Okay.
Yeah.
Okay. So, how often do you take these about?
Oh, not very often.
That's good. Okay.
Maybe once a month, but
Okay. So, any eye drops?
No.
Sometimes patients forget those little things that you can buy over the counter that really can give you some side effects.
actually,
with your
I don't
routine
need
meds.
them.
Good. Wonderful.
Do you take any herbal medications?
I don't think.
Okay. Sometimes we don't think of herbal medications as medications, but they are. So if you remember any, if you could let us know. And they also can have the same strong effects that a medication can, and they can also interact with your other medications. So that's why we asked
Gotta
that
watch
question.
that, yeah.
All right. How about when you're at home, do you have any difficulty opening or reading your bottles, your medication bottles? No. Good. Got some good strength then. Do you have any concerns about being able to afford your medications?
Sometimes. Some of them, they're pretty expensive.
Okay.
at
Do you
times.
ever stop taking the meds because you can't afford them?
No.
Good. Good. That's very important. Do you receive any help in taking your medications? Does anybody come and help you?
Well,
Help, like pour them out and stuff?
besides my daughter.
Yeah.
She
How often
fixes
does she?
them up for me
Okay.
for the week.
Just once a week I fill her med binder.
That's right.
so.
Okay. All right. All right. Do you have any other questions that you'd like to ask about your medications or would like to tell me?
Not really.
Okay.
One more question, Evelyn. Do you know what your medications are for? Has anyone reviewed with you about why you're taking each of your medications?
They
Okay.
tell me right before they give them to me.
Okay, the pharmacist or the doctor?
Both.
Okay.
Good. All right. Okay. Because you actually take your medications at home by yourself. I know Mindy that prepares them once a week, but we need to make sure that you understand cognitively every day what you're taking and why you're taking it. We're going to do like a little mental test, like a neural check.
Okay.
We do this for all patients that live at home alone. What I'm going to do is have you say 3 words, and then a little bit later we're going to ask you to repeat those 3 words.
All right.
Okay? The 3 words are penny, table, and orange. Go ahead and repeat them.
Penny, table, orange.
Good, good. Okay. Now what we're going to do is have you draw a clock with the numbers
All
on
right.
this piece of paper. Here's a pen. You okay, Evelyn?
Mm-hmm.
Good. And just draw the numbers on the clock. Okay, now I want you to draw, tell me that, put the arms on the clock to say that it's 9:25. Good, wonderful. Okay, go ahead and sit back and relax. Okay, now back to those 3 words. I want you to repeat those 3 words that we just reviewed a little bit ago.
Penny, table, orange.
Good. Okay. That's all I'm going to ask you related to your medications. A little bit later on, we're going to meet with a nurse clinician and a pharmacist related to your meds and discuss any changes that we might need to make.
Okay.
And then after your discharge, before you go home, a nurse will come in and review your medications, any changes that we might have made, and give you a list so you can refer to that list of meds that we might have made changes to.
That'll be fine.
Okay? Do you
We'll
have any
make sure
other
that you know what you were taking at the hospital and then what you should take at home.
All right.
So we'll make sure we review both of those lists together.
Okay.
And then if you remember any other medications that you're taking that you forgot to tell Janelle, just let us know, like eye drops or any kind of over-the-counter medication. You can always let us know.
Okay.
All right.
Well, thanks
Thank
for your
you.
time. It was
Thank
nice
you.
meeting you. And I hope you go home and don't fall anymore.
Thank you.
I do too.
Nice to meet you.
Same here.
Thank you. Can you just summarize what medications and how many she was on?
Sure. I have a list right here. Looks like she was on a total of 13 medications. aid including the prescribed medications from the physician. The aid included the amitriptyline, 50 milligrams, oxybutynin, 5 milligrams.
Let's compare these. I have the Beers criteria list here.
All right.
Remember the part 1 were medications to avoid no matter what in people over 65.
Right.
Because the risk of the medications are known to outweigh the benefits. So we'll see which one she's on from part 1. And then part 2 are medications to avoid in certain conditions. Conditions like if they have hypertension or incontinence or insomnia or falls. So we'll see which of those medications fall on these lists.
It looks like a lot to me.
Okay.
Just from running down. So we've got the amitriptyline.
Okay, and that's on the part 1 list because of its strong anticholinergic properties. So it has central anticholinergic, which can be confusion, falling, and she did have a fall. And it also can cause dry mouth, constipation. So that one's on the list. What else is she on?
She's also on the oxybutynin.
Okay. Oxybutynin is also on the list. The other thing is she has incontinence. Sometimes that can make stress incontinence worse. It can help urge incontinence, but there might be something safer she can be on.
Right.
So that's on the list. And the other thing is those are both anticholinergic meds. So she's already on 2. And what happens is the anticholinergic meds can build up if they're on multiple ones. Is she on any other that are anticholinergic?
I saw that she was on the diazepam, and she does take some Benadryl with the Tylenol for the PM for sleep.
Okay, so diphenhydramine is also anticholinergic, and that's also on the Beers list.
Okay.
And then the diazepam is actually on part 1 and part 2 because it's one of the things that people should not be taking if they're falling. And it also is on the list because it can cause confusion and falls, particularly the long-acting benzodiazepines that take a long time to get out of the body, sometimes as long as 50 to 100 hours.
And what about Darvocet, the propoxyphene?
Yes, propoxyphene is also on the list.
Because she takes that as needed just for pain, for severe pain.
Okay, so she's on 1, 2, 3, 4, 5. Any other medications? So far she's on 5 Beers meds.
I was concerned about the digoxin. She takes, it looks like 0.25, which in the Beers list, isn't it recommended less than 0.25 milligrams? Or
0.1, that's right. It is on the Beers list that not to exceed 0.125 milligrams. So that's one we can also ask the pharmacist and the nurse practitioner about.
Okay.
So she's on 6 Beers meds actually.
Oh my.
Okay. Any other concerns about her medications that you saw in general?
I did note that she took a lot of variety of over-the-counter medications, including the Aleve, the Tylenol, ibuprofen, and aspirin. Okay. She just seems to be taking different medications for different reasons.
Okay, so we'll also ask the pharmacist about that because it sounds like she's on a lot of duplicate medications and she's not taking them scheduled, so maybe that can be part of the plan to think about regular pain management and scheduled medications instead of as needed. Janelle and I assessed Mrs. Lyons together today. This is her second day in the hospital. Mrs. Lyons does self-administer her own medications, though her daughter does help her. She comes on Sunday and sets up the little medication boxes for her. And also, do you know you did a mini cog that was normal?
Yeah,
is that right?
Yeah, she actually did wonderful with that.
Okay, so her mini cog was normal?
Basically, I think her number one problem is the duplicating of medications and the medications that fall under the Beers criteria.
You're right, Janelle, I agree. She's new to our practice. Her attending doesn't have privileges here. So when she was admitted, I was the one who did the admission and read through her chart. And you're absolutely right about the duplication of meds and some of the meds that may not be the best choice for her given her age. The first one I'm concerned about is the oxybutynin. When I assessed her, I'm not totally convinced she has true stress and urge incontinence. I'm thinking it may be more functional due to her osteoarthritis and her difficulty getting to the bathroom. So it's good that you have her getting toileted every 2 hours and you have her on fall precautions. What I'd like to do is take her off the oxybutynin for now and to have her keep a record, or maybe you could keep a record for her of how often she goes and how much, as well as keep her on the every 2 hours bathroom visits. If she stays with our practice after leaving the hospital, we would have a chance to further work with her. And if she does need the oxybutynin, perhaps
There are some safer possibilities in that same general category. For one thing, just a sustained release version of the oxybutynin or a sustained release tolterodine would have fewer side effects but would be equally as effective.
Okay, that's good to know. And that would be an option later on down the line. The second medication, the amitriptyline, she's only been on that for, I think, 3 days, you said, and she was put on for the neuropathy. I have concerns about the amitriptyline because of its anticholinergic effects, its sedation, and the fact is, if she stays on it, it could make incontinence worse. At this stage of the game, I would prefer to take her off of it and evaluate the peripheral neuropathy myself. Is it really her osteoarthritis that's causing pain, and she's therefore interpreting it that way? Also, she's diabetic, but I didn't see any diabetic medications. I have ordered an A1C, but I'm waiting for the results to come back because she could need another medication for the diabetes. Her diet has been controlling it thus far, but she may need something else. If I control her blood sugars, I may minimize the neuropathy.
Absolutely right. Again, there may possibly be some safer alternatives to the amitriptyline if it does develop that she needs a medication for the neuropathy.
Okay.
Gabapentin comes to mind, although that is somewhat sedating. It has a lot fewer anticholinergic effects and cardiac effects.
The other related piece, she was taking Darvocet, propoxyphene for pain as well. She told me on really bad days, that's her medication of choice. For days when the pain is not so bad, she'll take Tylenol. Not only is she on the Tylenol, but I think in her medication list, she listed Aleve, naproxen, she listed Advil, ibuprofen, and then she was taking aspirin for her headache. All of those medications make me nervous because it increases her risk for GI bleeding. And one of the goals we have in the goals of the Beers criteria is to minimize the amount of meds they're taking as much as possible to keep things simple so things aren't interacting. I would like you to I'll tell her too, but if you can talk to her in your interaction and we can get her off the NSAIDs, just keep her on the Tylenol in the beginning. If she needs more, we can then go to an NSAID maybe later on down the road. But I'd like to try non-pharmacological pieces first. I'd like to try her on scheduled doses of Tylenol and see how her osteoarthritis responds. You mentioned the PT consult.
Yes.
I did write for that, and I'm hoping they can give her exercises and work with her while she's here to figure out ways to minimize her osteoarthritis.
Do you think you could also write for her to get a PT referral for home and maybe even send a nurse in too? That way they could assess her fall situation, because really we don't know if there are things at home that need to be assessed, like throw rogues and just the overall fall safety. And then they could also, while they're doing that, assess the administration of her meds. Though it looked like from your assessment, that she was doing pretty well with that, but certainly the falls.
Yeah, that would be a great idea. I'll wait for that too, because you can get one set of outcomes in the hospital, and then they go home to their own environment, and you have a whole new set of issues and challenges. So I'll write for that as well. I also, while we're talking about pain and Tylenol, she's also taking Tylenol PM to help her sleep some nights, and then she's developed this routine on Saturday nights of taking 10 milligrams of diazepam to help her get to sleep early enough so she can go to church. I have concerns about her taking that much Valium on a weekly basis. I wouldn't want her to take any diazepam at all.
Yes, I agree. A patient of her age, she probably has a very long half-life. The metabolites hang around for a long time in the elderly, maybe as much as 100 hours. And she would just be much safer using non-pharmacologic methods to help get to sleep. Since she's been on it for a considerable amount of time, I understand,
Yes.
we probably will need to gradually discontinue the medication, perhaps cut it in half for a few weeks. 5 milligrams, you said she takes 10
Right.
milligrams now, and then down to 2.5 for a few weeks, and then off, just to make sure that she doesn't get any rebound insomnia or other withdrawal effects.
And either Dr. Newman or I will write that in the discharge orders. I'm not sure which one of us will be discharging her.
And when she's discharged, we give all of our patients that are discharged a home med reconciliation where the physician will continue medications that they were on at home,
Right.
or change them or discontinue them.
Okay.
And we'll go over all of that in detail with her and review any new medications that she might be put on.
Okay.
Yeah, that's a great idea, because the transition between home and the hospital and back home again is the easiest place for mistakes and confusion
Okay.
to occur.
Now, getting back to sleep hygiene, I know that you have sleep hygiene measures that you can do here.
Yes.
Okay, what's all included in those?
We actually can implement as a nursing decision the sleep kit,
Okay.
which is pretty neat. There's a container that we can deliver to the room that has a little cassette that can play the radio or suggest maybe white noise.
Mm-hmm.
We can also just give her some warm milk at night,
Okay.
or possibly some herbal tea to help her sleep.
Okay. That'll be really good, and that'll get her out of the habit of taking the Tylenol PM and hopefully get her off of the diazepam as well. Last but not least is her digoxin. I know she has a history of atrial fibrillation. While she was on telemetry, she was perfectly fine. I don't know how long she's been on it. She wasn't sure herself. The 0.25 milligrams is...
The dose is a bit high. I was concerned. They generally recommend it for patients over 65 years old, just no more than 0.125 milligrams a day, sometimes less if the renal function is severely impaired.
Her renal function was normal, which was good to see.
Okay.
I'm also going to obtain a cardiology consult because she may not even need to be on it, but I'd prefer a cardiologist clear her for that decision. And that's all I can think of with the medications.
The end result should be that she's on fewer medications and safer medications. Does that sound like a pretty good plan to everybody?
Absolutely.
I think so.
What we know about inappropriate medication use in older adults is that it's very common. In studies of both community living older adults and those in hospitals, it's well over 25% of those individuals are on medications defined as inappropriate. And what we mean by inappropriate are medications that their risk is higher than their benefit in adults over the age of 65. This actually refers to specific medications that have been defined this way. And in all those cases, there's actually a safer alternative available, or a non-pharmacological alternative that would be a safer alternative to the inappropriate medication. Inappropriate medications can also refer to inappropriate dosages, inappropriate for the diagnosis itself. So maybe the medication is not appropriate for the condition that's indicated, or maybe the medication is not effective. Even though older adults represent about 13% of our population, they're prescribed over 30% of all prescription medications. When you take into account actually over-the-counter medications, 12% of our population is on 10 or more medications. We also know that for those adults that take 5 or more medications, 1 in 3 of those will actually suffer an adverse event. And in some studies that actually were done by Gerwitz and colleagues, they found that of those adverse events, about 30% of those were preventable. Some of the factors related to aging that put an older adult at high risk for a medication-related adverse event include just the fact that they're on more medications. We actually know when you look at study after study that the most important factor is the sheer number of medications that they're on. So usually our plan is to try to reduce that number. The second thing is age-related change. There's something called pharmacokinetics and pharmacodynamics. It's important to know how the drug interacts with the older adult body. Some of those normal age-related changes that affect medication use include changes in absorption. And actually, we don't have a lot of changes in absorption as we age, only a couple of those. So that's sort of the good news and the bad news. The bad news is that means that they get most of the medication. And then older adults have a lot of changes with distribution, and that means how the drug is distributed through the body, elimination of the drug, and then metabolism of the drug. And some of the most important changes are that we have decreased lean body mass as we age, and we have increased subcutaneous fat. So, example, there are many drugs that we call lipophilic or fat-loving, and some of those would be diazepam. Almost all of your short-acting and long-acting benzodiazepines will build up into toxic levels in older adults. So we'll give them a dose. We'll say, oh, it's not working. We'll give them a milligram more. We'll say, oh, it's not working. But all this time it's building up in their body and it becomes toxic. The other thing is they have decreased binding sites for albumin. So those medication, what happens is that there's more free drug available in the body, and again, it just builds up into toxic levels. Appropriately monitoring medication use in older adults is actually very complex, and there are several things related to that. One is that there are multiple players involved. For instance, the pharmacists, they may be going to multiple healthcare providers, they may be using 2 or 3 different pharmacies, so we don't know. Actually, it's just difficult to say what are all the medications that they're on. And even though it's recommended that older adults have an annual medication review every 6 to 12 months, we know that that's often not done, and studies have actually supported that. So it's in the first place, it's just difficult to get an accurate list, an updated list. It's also difficult, even if we have a list of prescribed medications, to identify those over-the-counter medications that persons are taking, those herbal medications that they might not think of as a medication. There are a few things that you can do to assess medications, and one of those is to make sure there's a family member available if at all possible. And the other thing is, if possible, to have them actually bring in medications at home so you can compare the list of things that they're taking home to the list that you have either in the patient's chart or from the emergency room. Though even that approach can miss some medications because sometimes they'll bring in just those that they think they should be taking. And so they might miss some that they keep at their bedside or that they just take every once in a while. Or again, they might not put over-the-counters in there. They might not put herbals because they might not think of them as a... So just sort of reconciling that list and coming up with an up-to-date list can be very, very complex. Not having an up-to-date medication list is a big problem for older adults because what happens is then they come into the hospital or they have a problem at home and we're not sure what they're on. The other thing that happens is we don't know. There can be drug-to-drug interactions that we're not aware of. They can be on medications that are duplicative. So what you see many times in the community and in the hospital is that people come in with a medication and they'll tell you the generic medication name and they'll tell you the brand name medication, and they don't realize they're the same medication. Now again, I do think we're getting better about this. One of the things that's happening is that some of the drug companies are working hard not to make medications that look so much alike, because that can be a problem. There really are 2 other main reasons why older adults have more medication-related problems. And one of those is the fact that they're just on more medications that are high risk. And there are actually medications that we consider high risk in younger persons too, but in older persons they're more likely to be on these medications, and when they have problems they're more likely to be serious. Some examples of that are the anticoagulants and the antiplatelet agents such as warfarin, heparin, your hypoglycemic agents, your antipsychotics, your sedative hypnotics, and your pain-relieving medications such as your NSAIDs and narcotics. So they're more likely to be on those medications, and those medications are more likely to be high risk. The second reason is we know as older adults age, they have more chronic diseases. Individuals over 65 are likely to have 3 or more chronic diseases. So in addition to age-related changes with drug distribution, elimination, and metabolism, we put on top of that chronic diseases such as renal problems, heart problems, that also affect the way drugs are cleared and metabolized. Nurses can play a very important role in preventing drug-related problems in older adults. Nurses are actually the last point of intersection between the medication and the patient. So nurses are in a key position to detect medication-related problems. They actually administer the medication, they monitor the response to the medication. The other thing is that medication problems are often very subtle, and nurses are able to see the whole clinical picture because they're the most, in terms of being they have the most interaction often with the patient at the bedside. The other problem is that oftentimes the time during a hospitalization and that 30 days afterwards can be a key time when the nurses can do important discharge teaching about medication-related problems. As we saw with Mrs. Lyons, the nurse is in a key position also to interact with the family, because we know that many times with medication-related problems that those changes can be very subtle and that we don't know what's happening in home. So the nurses are able to get the whole clinical picture, to get information from the family, and then to relay that back to the rest of the team and get the input of the pharmacist, the physician, and the other healthcare providers, and then bring in those other team members. The other point I think that's important is that nurses may not prescribe the medications, but they're often the one that's interfacing with the physician or the healthcare provider that's prescribing those. Nurses often take the lead on many of the non-pharmacological treatments that would be a good substitute for some of these medications, and they can actually inform the other providers about these. Many of the protocols that you see for sleep, for cognitive therapy, for disturbing behaviors are actually led by nurses. So again, nurses are in a key position to help educate other providers about some of these things that can be done in substitute of medication. And again, getting back to that overall goal with Mrs. Lyon, which is to decrease the overall number of medications, because we know the fewer medications they're on, the less chance they have of having a drug-related problem. There are actually several tools available for nurses to assess medication use in older adults. One of those tools is called the Beers criteria. The Beers criteria was actually first developed in 1990 and then updated again in 1997 and then again in 2002. And the Beers criteria has 2 parts. Usually when we talk about tools, we talk about explicit criteria and implicit. And the explicit criteria are actually a specific list of medications, and that's what the Beers criteria are. There's also criteria called the Canadian criteria, which are a little bit similar to the Beers criteria. In the Beers criteria, there's Part 1, which is a list of medications that you should avoid in any adult 65 or older, in any setting, whether it be the community setting, acute care, or nursing home. And many of those medications have central nervous system active properties, so they lead to confusions and falls. Some of those medications are more likely to lead to GI bleeds. A few of the medications that are on there, for instance, are diazepam, flurazepam, which is a sleeping medication, propoxyphene, which is Darvocet. And what we know about these criteria is that they were developed by an expert panel after they did a comprehensive review of the literature, and then they looked at medications to say, do their risks outweigh their benefits? And then thirdly, is there a safer alternative available for this? And sometimes that's a safer medication, and sometimes that's a non-pharmacological alternative. The second part, Part 2 of the Beers criteria, or Table 2 in the article, are medications that should not be taken with certain conditions. So it might be medications that shouldn't be taken with Parkinson's disease, or medications that shouldn't be taken when someone's having falls or syncope. An example of that would be long-acting benzodiazepines or amitriptyline or other tricyclic antidepressants, because we know that'll make that condition worse. Staff nurses can use the Beers criteria, particularly Table 1, which is the list of medications that should be avoided in older adults over 65 no matter what. and they can use these medications as a guide. For example, in the case of Mrs. Lyons, the nurse Janelle was able to identify that she was on 6 medications that were on the Beers criteria. But that's just a screening guide, and a patient or a nurse should never recommend that a patient stop taking a medication just because they're on a list. So what would happen is the nurse would use the Table 1 to identify medications that the patient might be on, and then go back to the whole team to discuss what the plan might be and to look at the whole clinical picture in regards to these medications that are on the Beers list. Part 2 is a little more complicated because Part 2 of the Beers criteria, or Table 2, is associated with certain conditions. So again, they would have to know the conditions, would have to know a little bit more information. But with a team assessment and a team discussion, they should be able to use the Beers criteria to guide that plan and to, again, to reduce the overall number of medications. Beers criteria needs to be part of a comprehensive review of all the medications that the patients are on. For example, in the case of Mrs. Lyons, we didn't just look at the medications she's on, but we look at, are there any potential drug-drug interactions? Are there other drug disease interactions that are important? What are her electrolytes and her laboratory values associated with those? Are these drugs that are indicated for a certain condition, and are they effective? Are they working? The other issues are things like, can she afford the medications? Can she self-administer her medications? For instance, we did the mental status assessment with Mrs. Lyons, because if anyone is self-administering their own medications, you have to know what their baseline mental status is. So again, it's part of a comprehensive assessment. The Beers criteria were developed to be used in all older adults, and actually across all settings. So it could be used in home care, in the community, it can be used in assisted living, nursing homes, or in the hospital. The Beers criteria should be done at least annually, anytime there's a problem. They can be used as a guide anytime you see a change in mental or physical functioning, and in the hospital they should be done at admission and then again at discharge. There are some other resources for nurses that are further interested in assessing medication use in older adults. There's the companion article from the American Journal of Nursing that goes with this video. There's the Hartford Institute website. There's also the American College of Physicians has a peer module for drug prescribing in older adults. There's also the American Society of Consultant Pharmacists that has an area that has special emphasis for older adults and prescribing medications. Another resource for nurses is the Institute for Safe Medication Practices, because this focuses those high-risk drug categories that we talked about, such as the antiplatelet agents, the insulins, the hypoglycemic agents. That resource actually highlights some of those drug classes that are considered to be high-risk medications.